This is Open Door with Vince Robinson. In-depth conversations with people who are making a difference in the lives of others here and around the world. Culture is at the heart of who you are. Know your culture, find yourself on Open Door with Vince Robinson.
Greetings and salutations. Welcome to another edition of Open Door with Vince Robinson. I have today with me an icon in Cleveland's health community, the medical health community specifically. He is an assistant professor of surgery at Case Western Reserve University. He's also a kidney transplant surgeon and is the founder of the Cleveland Clinic and MetroHealth Minority Men's Health Fair. He's a national visionary health equity leader and champion, personal success mentor and coach. He's a motivational speaker, book author, and he has written a book called It Isn't Difficult to Do It If You Know How to Do It. And he's also a multicultural medicine consultant and advocate. Graduated from Northwestern University and Northwestern University Medical School, completed a 6-year residency in urology at New York University, a 3-year fellowship in kidney transplantation surgery at Cleveland Clinic, and he joined the Cleveland Clinic staff in 1996. He's a noted national leader for eliminating health disparities, as well as a strong national proponent for educating and informing minority communities regarding the importance of organ donation and increasing minority access to kidney and organ transplants. I'd like to welcome to Open Door with Vince Robinson, Dr. Charles Modlin. Dr. Modlin, how are you today?
Well, I'm doing very well. Just trying to stay warm. It's a great honor for me to be able to be on your platform, and so thank you for having me. I really appreciate it.
Yes. In transparency, I would mention that I was part of a podcast that you did with Carol Malone a couple of years ago, and you told your life story, and I was really fascinated. So I'm really happy to share these things with you. I might also add that somebody close to you named Trey Modlin is actually one of our announcers here at WOVU 95.9 FM, Cleveland's urban alternative. So you've had a tremendous impact on Trey, and I think the world is a better place because of that.
Well, thank you.
Just wanted to
he's a great son. I'm very, very proud of him.
Yes. Well, he's doing great work, and we appreciate him so much. So you have an advocacy for men's health. Before we get into your life story, I just want to give you an opportunity to talk about how that came about and why it's so important for you to advocate for Black men, especially when it comes to their physical health.
Yeah, so thank you very much. So as you mentioned, I'm a board certified urologist, kidney transplant surgeon. But kind of just briefly get into how I developed a passion and advocacy towards improving the health in minority communities, not just men, but for minority communities in general, because of the increased incidence of health disparities, higher rates of chronic disease, lower life expectancies, especially experienced by African American populations. I grew up in a small town in central Indiana back in the 60s and 70s. And growing up, I had certain lived experiences, but, as I was growing up and as I was, a young boy, my father would always be telling me nobody cares about Black men. And, as a young kid, I didn't really understand. It didn't really resonate entirely what he was talking about. But as I grew and had additional lived experiences, as living as a Black man in America, I had a better understanding of what he was speaking about. And he, in his own right, was a civil rights leader down in Newcastle, Indiana. And as I grew up and graduated from high school, I was actually the first male from my family lineage to actually graduate high school. My father would have graduated. He had to leave high school in the 11th grade in good standing so he could enlist in the United States Navy during World War II, to serve his nation. But as I graduated high school, went to college, my father was always proud of me, but he always reminded me that it's my responsibility to use the education that I had been fortunate enough to receive, because there are a number of individuals who were not in the position that I was to be able to take advantage of, educational opportunities that he and my mother had provided me. My mom was the first Black school teacher in the history of Henry County, Indiana. She became a school teacher at age 40, and you can imagine some of the challenges that she faced, being the first and first ever Black school teacher in that entire county's history. But my parents instilled within me and my siblings, the importance of acquiring and achieving the education, that we could achieve. And so as I grew up and matured, my father always reminded me to use my education to give back to the community. Fast forward, I became a urologist. And as you know, urologists, we're surgeons, but we have subspecialty interest in men's health as far as prostate cancer, testicular cancer, bladder cancer, kidney cancer, diseases and conditions of the urinary tract. And as you know, prostate cancer develops twice as often, and twice as many black men die from prostate cancer compared to white men. So I'm putting all this together. Note what my dad said, his admonition to use my education to give back to the community. Nobody cares about black men. And how all this came about, my fascination and focus on improving black men's health is back in 2003. My family, we went on a spring break down to Cincinnati, Ohio, and we visited the National Underground Railroad Freedom Museum. And I became very angry seeing a lot of the slave, the historical representation, actually pictures, the actual shackles that, our ancestors had endured. It actually made me angry seeing what our ancestors had to go through. And so I remember driving back to Cleveland. I was sitting in the organ preservation lab at Cleveland Clinic, and I had an epiphany. Everything came to me at once. What my father had told me. And as a urologist, I knew that I could use my urologic skill sets, my expertise in addressing men's health issues to create a niche program that would actually help address the healthcare disparities that especially black men endure. And it took me, a little while to really understand how I could best, create some kind of programming. But I had to study and figure out why is it that black men suffer the highest rate of chronic disease, the lowest life expectancy. And then I realized, and I had help in doing so in becoming part of the community because I'm not actually from Cleveland. So I had some individuals, especially a gentleman named Mr. Robert Allen, who introduced me to Reverend Cavanagh, Reverend McMickle, Dr. Otis Moss, Dr. McMickle, Dr. Macon, number of very important, influential members of the community who basically took me under their wing, introduced me to their parishes and parishioners, who helped me develop a trusting relationship with the black community. And with all of that came establishing the Cleveland Clinic Minority Men's Health Fair, which grew over a period of number of years, over 20 years. But the purpose of that health fair was to educate the black community, especially men of color, to understand the importance of undergoing preventative health screenings for the early detection of disease. You don't just wait until you have pain, discomfort. There are ways in which to address what could be serious health conditions before they advance to untreatable stages. Not only to educate, but to empower men to take advantage of the free screenings that the leadership of Cleveland Clinic was allowing me to provide, these gentlemen. It wasn't just limited to black men. All, women, men of all different races, ethnicities were welcome. But over 20 years, we actually provided free health screenings to nearly 30,000, predominantly, men of color. We had every year about 650 volunteers from Cleveland Clinic and from the community come together to serve these individuals. And it really changed the lives of literally thousands of individuals. And so I know that's a long-winded story, but that's actually how all this came about. And as you know, when you get involved with an initiative and it's successful, it just makes you want to continue to grow it and do even more, for the community. And it continues to be one of my major passions, even today, as we sit here today.
Yes. Well, it does definitely have a tremendous impact. I can just recall over the years, year after year after year, I would hear about that fair. So there was definitely very effective marketing in it, and I'm sure that there are lives that were affected as a result of that. I want to rewind a little bit and talk to you about your father's observation about black men.
Right.
Where was it that you think he got the idea that black men were in the position that they were in, and that he would share that with you?
Yeah, sure. So it was real. I mean, it was a culmination of his lived experiences. So both of my parents were born in 1924 in central Indiana. They both grew up and survived the Great Depression. And so it was really just lived experiences. He would talk about how, he had one brother, one sister. His father, was a single parent. And he told me, I mean, quite literally, they were always hungry, food and impoverished. And, they did what they did just to, be able to put food on the table. And I remember when I was growing up, my father, could be 8 years old, 10 years old, 12 years old. On Saturday mornings, he would take me downtown Newcastle, Indiana. We would wash windows of storefronts and auto dealerships, and we would mow grass for people in the community. And he held usually about three different jobs. He worked in the factory. After he left the Navy, he was in the Navy for 7 years. Went back to Indiana, worked in the foundries and the factories. He had me actually when I was in college in the summer working in foundries. And after I got off work, I was lying on the floor, exhausted. He was outside mowing the yard, So, but no, it was just his lived experiences. The growing up through the Jim Crow period. Again, Indiana during those times, perhaps even today, in certain respects, is more representative of the deep South. And so, he experienced a lot of racism growing up. And, he wasn't afraid, and this is very important, he wasn't afraid to try to hide his experiences from me. That was his way of preparing me of what I was going to be facing when I became, a black man. So he wasn't trying to shield me from the truth. I think it's very important that we be honest with our children about what we've been through, and the goal is to make life easier, for our children than what it was for us. So I thank him for that, because he did prepare me to be able to become a servant of the community now. And he always reminded me, and he was a very religious man. We were in church every Sunday. He was the lay leader. But he always reminded me that, and he always said this to all of my siblings, Jesus was a servant. So if Jesus could be a servant, why can't I also be a servant? So, he taught me by, me being able to observe how he took care of the community. He would go downtown and clean up the streets. Nobody was paying for him to do that. But there is one incident I'll tell you real quick. When I was about 14 years old, my father actually helped a man become elected mayor, a white man, of course, in Indiana at that time. And the mayor, the newly elected mayor, rewarded my father with a job, giving him the position as park superintendent. But what happened, and my father was the kind of individual who didn't lead from behind a desk. He was out there in the fields, in the streets, in the parks, working even harder than the men that he oversaw. But what happened was those men didn't want to be led by a black manager, park superintendent such as my dad. So one evening, my sister, Becky, she had my father's car over at the high school. A number of individuals stole my father's car, drove it to the center of the park, and set it on fire. So, that's one stark example of where I saw racism at its worst, where it actually affected, my family. And again, I've seen this myself growing up. So, I take it very seriously, when I say that it's my responsibility as a black physician. Again, there are a number of individuals who could have gotten my seat in medical school, but I was fortunate enough to have gotten that seat and received the training. And it really is my responsibility to do what I can to go above and beyond to help the community improve their health outcomes. Because, again, I'm fortunate enough to be having been put in this position, and I know I didn't get here just because of my own efforts or on my own accord. There were people who helped me get to where I am today.
Yes, and I wanted to follow that up because I know that going through the medical school experience is not necessarily an easy thing. It's probably one of the most expensive educations that you can acquire these days, and perhaps it was back then. So how were you able to come from such meager beginnings to attend Northwestern University and Northwestern University Medical School, and then that 6-year residency at New York University?
Yeah, so I had, some scholarships. I was fortunate enough to get some scholarships that allowed me to. So I graduated from Northwestern University at the undergraduate school in 1983 with a degree in chemistry. I had, some scholarships, from high school, some, federal grants, that kind of thing. My parents did what they could to send me money to help, augment whatever needs, financial needs that I had. But I'll tell you what, and at the time I didn't even tell my parents this. So at Northwestern back in those times, I was on the school meal plan, and so on Saturday for lunch, I was able to eat lunch on Saturday. But then, we're talking back in the early '80s. Northwestern, the food service, they didn't serve food from 1 o'clock on Saturday until breakfast time on Monday morning. There were several weekends where I didn't have anything to eat. I didn't have any money to buy food. So what I would do a lot of times during the week, I would kind of load up on, taking some apples, bananas, bread, things of that nature, from the cafeteria, so I would be able to have something to eat. Back then, there were no real restaurants anywhere near the campus. Especially in the middle of the winter, up in Chicago, it wasn't easy to get around. So yeah, I actually, I had food insecurity myself, as a student, but then actually in medical school, I received some scholarship money from what they call the National Medical Fellowships. That's a national organization out of New York City that provides scholarships to predominantly students of color. They've expanded that to, all students, of course, now. So I had help, but you mentioned the cost of the exorbitant cost of medical school. I can laugh about this now. 1 year before I started medical school at Northwestern, they did away with what they called a debt ceiling. They had a $100,000 debt ceiling where medical students at Northwestern, they would not allow to accrue any more debt than $100,000. So about a year before I got to the medical school, they did away with it. Meaning that I had much more debt than $100,000, leaving medical school. And I just, quite honestly, just paid those off probably 15 years ago, that medical school debt. So I'm actually grateful that I had the opportunity. Every chance I get, I thank Northwestern for giving me the opportunity to go to medical school there. As an intern and resident at NYU, you don't get paid a lot, but it's something that I've just, it's going into, if you want to be a physician, it's going to be a long haul, and you don't go into it for the money. If there's any students out there who think they want to go into medicine, to become wealthy, then they need to rethink what their, what their thought process is, what their motivation is. But it's quite expensive. I did 17 years of training after high school to become a kidney transplant surgeon and board certified urologist. But again, I did it for a purpose because I wanted to serve the community in this fashion. It's been really pleasurable to be able to put a kidney transplant into a patient and then see the kidney work immediately in most situations, and the patients are then off dialysis and living as normal a life as possible. And it's quite rewarding to have patients come up to you and tell me, well, you did my kidney transplant at Cleveland Clinic, or you took care of my prostate cancer, that kind of thing. It's a very rewarding profession. So we get a lot of satisfaction by taking care of patients, as the patients get rewarded by, our abilities to take care of them.
Mm. You mentioned earlier the fact that Black men suffer from prostate cancer at a disproportionately higher rate than white men do. But I was wondering why you chose urology out of all of the choices that you could have made in terms of what direction you would head in on your medical journey.
Sure. So the way it works, and there are some students who may be going into medical school already have in their minds in terms of, what type of physician or surgeon they wish to be. And by the way, there's a growing shortage of urologists and many subspecialists, but there's a huge shortage of primary care physicians. So we need more primary care physicians. But the way it generally works is you the first 2 years in medical school or in the classrooms, there's been some change in the curriculum with it. And then the third and fourth year, you go out and do your clinicals, and that's when you're really exposed to the different branches of medicine and surgery. And it was I had a great mentor, a guy named Dr. James Holland, whom I was able to shadow when I did my urology rotation. And I just gravitated towards, the field of urology. It's a mixture of surgical treatments and medical treatments. I enjoyed the types of operations, that urologists did. But a major reason why, and I thought about going into general surgery, I thought about going into neurosurgery, gastroenterology. But I remember, and I laugh about this now, when I did my general surgery rotation, a lot of the surgeons were kind of very mean and it wasn't really a pleasant environment, but the urologists seemed to be a bunch of nice, a bunch of nice guys. See, at the time, there were not really any women in urology for the most part. Now there's a number of women, urologists, which is great. But I just gravitated toward the field, and I enjoyed the people that I was working with.
Okay. Just curious about how treatment has changed or evolved over the years. I know there may be some dietary reasons, there may be some lifestyle factors involved, but I know that there are probably improvements that have happened in the way men are treated for prostate cancer. So could you elaborate on possibly the changes that have taken place or new ways or methods of dealing with it?
Yes, sir. So there have been a tremendous number of changes. Since I was a resident at NYU, and even since my early staff days at Cleveland Clinic. For one, there are different ways to screen for prostate cancer as opposed to when I started my training. Back then, years ago, we would do what we call digital rectal examinations, or DREs, on patients to palpate. That's where we stick, a digit into the rectum of the male and palpate the surface of the prostate for any lumps, hard nodules, we call it. But in that situation, if you're able to palpate or feel suspicious area of the prostate, 50% of those individuals already had advanced prostate cancer. Nowadays, there's a simple blood test called a PSA, prostate-specific antigen, to where we don't even, in most situations, even have to do that rectal examination. And I say that because a lot of guys are fearful of going in to the doctor to get screened for prostate cancer because they fear getting that prostate exam, that rectal examination. So I'm here to let the guys know that in most situations, we don't even have to do that. Just a simple blood test. That's one major thing that has changed. But another important way, or way in which we diagnose and treat prostate cancer, is the fact that not all, and see, before any man who was diagnosed with prostate cancer, we thought every man with prostate cancer actually had to be treated. And that treatment consisted of either surgery or radiation. And there's different ways to do radiation, external radiation, or radiation seed implants, brachytherapy. Nowadays, if a man, there's different grades of prostate cancer, meaning that all prostate cancer doesn't behave the same. Some some of it is more indolent or less aggressive than other types of prostate cancer. And one of the major changes is that now we can do what we call active surveillance to where not every man who's diagnosed with prostate cancer needs treatment. We can follow those gentlemen over a number of years to where many of the individuals won't need treatment during their lifetime. And, we don't want to obviously have to treat a patient that we don't believe that the prostate cancer is going to progress or cause a problem, because we don't want to have the patient undergo unnecessary surgery or radiation or experience any, side effects, complications. There are different ways also. Now we in most situations, not all, we will do what we call an MRI of the prostate. That's a imaging study to where we can look at the imaging of that MRI exam to determine, if we need to, when we're contemplating doing a prostate biopsy, if we want to target specific areas in the prostate, which will increase the sensitivity or the detection rate of getting a true and, not a false negative reading. So there's better diagnostic accuracy. There's better treatment paradigms or options for patients diagnosed with prostate cancer. And another big change since I was in training is minimally invasive surgery. Laparoscopic, or now it's called robotic assisted radical prostatectomy. In the past, and I did a number of these over the years, radical prostatectomies, that's complete removal of the prostate with an open incision. Now that's very rarely done. It's done using laparoscopic ports that are inserted through the abdominal wall. All this is done under anesthesia, of course. And then those ports those trocars are hooked up to a robot where the surgeon sits at a console and then has a more meticulous control of their movements, as opposed to, making a large incision, putting your hands into the patient. It's minimally invasive, less blood loss, quicker recovery time, less postoperative pain. So, yeah, there have been a lot of advances. And then there's also advances in treatment of men who have advanced prostate cancer, whereas before, if somebody had advanced prostate cancer, we were kind of relegated to either using hormonal therapy or doing what we call an orchiectomy. So, yeah, no, and that just underscores the importance of innovations in research and surgical techniques. Okay.
So we've talked about diagnosis and we've also talked about treatment. Let's talk about causes and prevention. What is it that causes Black men to suffer from cancer, prostate cancer, as well as anyone else? But what are the causes of prostate cancer?
Well, see, quite honestly, we don't have an exact, we can't pinpoint an exact cause why any one man will develop prostate cancer. We do know that there are certain risk factors. I mean, one risk factor, and I'll get into the more details of this, but one risk factor is being an African-American male. Another risk factor is smoking, heavy smoking history. But another risk factor is your family history. We do know that there is a greater risk of any one individual man acquiring prostate cancer, developing prostate cancer, if you have a first-degree relative who themselves had prostate cancer, your father, your brother, your uncle. So we do know that there's a hereditary component to that. But a lot of it has to do with environmental exposure also, and I'll give you an example. So there have been studies of Black men in Africa, on the continent of Africa, who actually have a very low incidence of prostate cancer, but there have been studies that have studied men who have moved to the United States, North America, the Western culture from Africa, and then their risk of developing prostate cancer goes up. So it has something to do with the Western diet, the high fatty intake. Some people think stress may be, have something to do with it. Some individuals think there may be some kind of immunological or infectious etiology. We don't know exactly. And I'm glad you brought this question up, but it underscores the different recommendations as far as screening for prostate cancer in Black men versus Caucasian men. And not all doctors are even aware of this, surprisingly. So the recommendation is that Black men should start screening for prostate cancer at age 40, again, with that blood test, PSA, whereas white men don't have to start screening for prostate cancer until they hit age 55, unless they have a strong family history themselves of prostate cancer. That's a 15-year differential based on your race. And technically, there is no such thing as race. It's a social construct. But in practical terms, when you're talking about population health, those individuals who self-identify or we ethically and morally identify as African Americans, you got to be ethical in terms of how you look at individuals and not discriminate. But if you look at the large population, we do know that black men have twice the incidence and twice the death rate from developing from prostate cancer. So we call this race-based medicine. I know some individuals may consider that controversial, but other examples of race-based medicine are that African Americans in general respond preferentially to certain classifications of high blood pressure medicines compared to whites who respond to different classifications than blacks. There's in treating congestive heart failure, African Americans respond to different medications, and in treating organ transplant rejection or trying to prevent rejection, the immunosuppressive medications, African Americans require higher dosages. And again, a lot of that's because we have higher levels of the P450 enzyme in the liver that metabolizes medication. So that just underscores the importance that we need researchers, the pharma companies to, continue researching better medical therapeutics in certain populations. We need African Americans, minority populations to agree to participate in clinical research. We know the distrust that's out there, Tuskegee syphilis and other egregious actions that actually had led to a lot of distrust, unwillingness for blacks to participate. But it's very important that we actually do participate because, again, we metabolize certain medications differentially. We need to develop more medications that are going to be more effective and efficacious, in blacks and other populations.
Well, that was a very telling bit of information that you shared about African men who come to America and then are affected. It was also interesting that you would say that, white men would be off the hook for another 15 years. But I think the consistent thread for the African who comes to America and the African American man in America is experience based on the perception of race, even though it might be construed as a social construct. So that was quite revelatory from my perspective. So we talked about some of the things that are involved. I'm just wondering if there's, and you said you didn't really know that there was any identifiable cause. But I'm just wondering if there are any choices that men can make within their lifestyle to perhaps stave it off or prevent it or make it less severe than it could be.
Yeah, we think it's related. I mean, and there are some individuals, there's been some research that suggests there could be maybe some type of virus that turns on certain, genes that then, predispose individuals to prostate cancer. No, give me your question again.
I was just wondering if there's anything that we can do to perhaps prevent it from happening.
So, I mean, a lot of it has to do with, we think, the Western diet, consumption of, high fatty foods. I mean, the recommendation is that we all, to avoid developing diabetes, heart disease, stroke, colorectal cancer, prostate cancer, we should all subscribe to eating what they consider to be a heart healthy diet. There's been research, suggesting that, should men take selenium or vitamin D, those really haven't really panned out. But again, we think environmental exposures, I think there's more and more research that suggests chronic stress can, predispose us to lowering our immune, systems, which can actually make us more susceptible to developing cancer. Sedentary lifestyle also, we believe, contributes to higher rates of prostate cancer, colorectal cancer. there is actually what is believed to be a genetic association between in black men who develop prostate cancer and if their mothers or grandmothers actually had breast cancer. So that's why we think there is maybe some kind of genetic link. And it just underscores the importance that in the black community and several different communities, a lot of times it's taboo for us to even speak to one another in our families about the medical conditions that are prevalent. Historically, we as a group of individuals, we don't sit around the dining room table and tell our kids, okay, well, we have a higher rate of prostate cancer, diabetes, this, that, or the other. But it's important that we do. I mean, we want to prepare our children to what type of health screenings they're going to need to pursue, when they reach a certain age. And the other thing is, the goal is to empower the black community, all communities, if they're not getting a certain screening, that they believe they should be getting or know that they should be getting, then to speak up and request or demand those screenings from your healthcare provider, whether it's an advanced practice provider, physician, nurse, whoever it is. And that's where raising and educating the community and raising their health literacy is so important, because we need to empower them to be able to go out and ask questions about what screenings they should be getting. It's been recognized by the medical profession for decades now. We can't just be in the sick care. We need to be more proactive and identify, diseases while, try to prevent diseases, chronic conditions. But if these diseases exist, we want to diagnose them in earlier stages where we can do something about it.
Well, I think you brought up a really important idea, and that is health literacy. Because one of the deficits in terms of our learning, our education is health literacy. And I would even extend this to the medical profession, because what I do know about it is that physicians rarely receive an excessive amount of nutrition education. And when you look at the causes of disease, a lot of the disease is not just prostate cancer, but, all types of cancers. They're related to the things that we ingest. And when you look at the standard American diet, you see a lot of processed foods, you see a lot of endocrine disruptors, you see a lot of things that can be problematic, that cause issues that are customarily treated with surgery and pharmaceuticals. So sure. I think that, and this is just me being someone who has, delved into the holistic remedies and that type of thing. But I just think that it's really important that we do a better job on all levels of educating people about the things that they eat, and also the connection to their emotions. You're a urologist, you deal with kidney transplants, you have patients that might require dialysis. And from what I know from a holistic perspective is that fear is one of the causes of kidney dysfunction. Can you collaborate or corroborate the connection between emotional imbalance and issues with kidneys?
So, and not just kidneys, and it actually gets, there's a new evolving area of medicine called epigenetics. You probably heard of it. Yes. It basically just, it's a phenomenon that actually relates to how we still suffer from the indignities and the stresses that our ancestors went through 400 years ago, where there's not necessarily alterations in our DNA, but the way in which our DNA is expressed and translates into the proteins that become active in our bodies. And I say all that to point out is that, to your point, chronic stress, whether it's through overt racism or microaggressions that we experience on a daily basis, being black in America, can raise our blood pressure, because chronic stress raises our serum cortisol levels. That's our stress hormone, which in turn increases the incidence of high blood pressure that we experience, which can put strain on the heart, cause strokes, peripheral vascular disease, and then kidney disease. I mean, the major causes of kidney disease, kidney failure, or high blood pressure, diabetes, or a combination of both of those. So yeah, there can be a direct correlation between chronic stress, being exposed to racism, microaggressions, and the physical manifestations of disease, and it's a vicious cycle. When we have chronic stress, we develop chronic disease. It's more difficult for us to be able to go out and work and go to school, receive our education. It's a vicious cycle, and it's only getting worse because I contend that healthcare disparities are a national crisis. When we hear about a national crisis in today's society, really the only thing we hear about is climate change as a national crisis. But actually, I contend that health disparities are a national crisis. It's been projected, I believe, in the year 2036, could be a little bit longer, could be before, minorities are going to become the majority percentage of this nation's population. And look at it this way, if minorities have a higher incidence of chronic disease, lower life expectancies, that's not going to only impact the overall health of the nation, it's going to impact every aspect of society as we know it. Right now, healthcare disparities cost the nation over $500 billion a year, and that's old data. And that's going to impact the labor workforce, the GDP, or, you're not going to be able to have individuals enlisting in the military. Our youth, our adolescents, and our young people are not going to be able to focus on going to college, getting an education. I mean, it's going to impact everything.
Yes.
So, yeah, health disparities are a national crisis, and you're going to be hearing more and more about the work that I'm doing with respect to that in the coming months. But this is there's something that all of society needs to do to band together to solve this crisis, not just healthcare institutions or medical researchers. All of society needs to get on board, come together to solve this healthcare disparity crisis.
Yes. Well, you mentioned the climate change as a crisis. I think we've also recognized that racism is a public health crisis.
Oh, exactly. Exactly.
So,
and a lot of people deny that it exists.
Yes. Well, I mean, looking at the experience of your father and those who came before him, and the evidence that you gave us that an African man could come to America and have have a disparate effect on his health, that's a very telling kind of thing.
Exactly.
Yes. We talked about prostate cancer. You are also involved in transplanting kidneys and extending people's lives as a result of that. Is there anything that you want to share with our listening audience about the importance of, looking into the kidney issues and what might be involved in obtaining a transplant?
Yeah, so as I indicated, the leading causes of individuals developing kidney disease, going on to develop kidney failure, we call it CKD, chronic kidney disease, is high blood pressure and diabetes, one or both of those conditions. And one of the most important points I should make is that you can have severe high blood pressure, severe diabetes, not even have any signs, symptoms, or even know that you have it. I've seen a number of individuals who show up in the ER and they're diagnosed with kidney failure. They didn't even know they had kidney disease. And then they're relegated to be put on dialysis. African Americans, there's some changes now in the allocation, the organ donation system, to where there's more parity now, but still African Americans wait longer to receive a kidney transplant while on the waiting list. Actually, African Americans are less likely to be put on the waiting list, wait longer on the waiting list, have higher rejection rates after transplant, are less likely to complete their evaluation, less likely to have a living donor. The best way to get a kidney is from a living donor. And many of us don't know that, about living donation, that we can actually be a living donor. So again, it goes about raising the health literacy, educating the community about the importance of registering to be an organ donor, after your demise. A lot of people, when we get, like you mentioned, it gets into the distrust. A lot of individuals, I hear this almost on a daily basis, that they feel that if you register on that organ donor registry, if the doctors find out if you wind up in the ER and the ICU, they'll let you die to be able to snatch your organs to give to another individual. That there are safeguards. That doesn't happen. The individuals who do the organ procurement, who decide at the time of somebody's death, if somebody will qualify to be a donor, is different than the group of surgeons who are actually transplanting, receiving that organ. So that's a fear that, it's a myth, it's a misconception. That's prevented a lot of individuals from, and I've done focus groups in the community, and they've told me that's prevented a lot of individuals from becoming organ donors, living donors. It's something that we need to educate the community about. And here's another reason why is that, African Americans can do just as well as receiving kidneys from white individuals, Asians, doesn't matter which race, you can do quite well receiving a kidney. But actually the outcomes are still better if we can receive a kidney from an individual from another African American, because there's better matching. They call it the HLA matching system, lower rejection rates, that kind of thing.
Go ahead.
Oh, no, go ahead, please.
No, I was just thinking as you were talking about this, that there was a report that I listened to on NPR a few months back where a woman actually received a transplanted kidney from a pig.
Mm-hmm. There are, they've done over the years, over the decades, and none of those, they call it xenotransplantation from a different species to humans. None of those really survive long term. And a lot of it's because of rejection, and also, different species have different viruses, which when transplanted into humans can be life-threatening. You got to remember, in order to overcome or as an individual, a virus or bacterial infection, our immune systems have to be active to actively fight that off. Even we fight off cancer cells through our immune system, but when a kidney or organ is put into a recipient, we have to suppress their immune system so they don't reject that organ. So it's kind of a double-edged sword. But the more education needs to be out there. People need to know, the actual facts and not the misconceptions, about organ transplantation. Receiving an organ from a living donor is much better. And I'll tell you real quick, one reason why African Americans are less likely to be even referred for that initial evaluation is a lot of them don't know that they can refer themselves. They think they have to wait for their primary care physician or nephrologist to refer them to a transplant center. That's not true. But a lot of it has to do with the fact that many individuals don't have a strong social or family network. So when they go for that evaluation, that transplant center, and during that pre-transplant evaluation is evaluating the whole patient, not just their medical situation, but their social situation, to make sure they're going to show up for those required follow-up visits, that they're going to take their medication as prescribed, because there are not enough organs to go around to meet the demand, the people in need. So those transplant centers want to be certain that they're going to transplant that organ into somebody who's going to be responsible and take care of that organ. So, and also a lot of times we see in minority populations, they may not complete the necessary pre-transplant evaluation process, getting the colonoscopy, the mammograms, and stopping smoking. They're not going to transplant an individual who smokes. You have to demonstrate that you're not smoking, drinking alcohol, that kind of thing. So there's a lot of social reasons as to why many African Americans are not even referred or actually listed to receive a kidney transplant or another organ.
Yes. Well, what you're saying is it really comes back to lifestyle. And I was just thinking as you were speaking, what we should be doing is looking at ways that we can not have diabetes and looking at ways that we won't have high blood pressure so we don't end up on the surgeon's table having a kidney removed and replaced.
Exactly.
That's my thought. That's my thought.
But
Dr.
the thing is, they're some of the diabetes that we experience and high blood pressure, there are hereditary components. But to your point, that doesn't mean that just because our parents, our siblings, our ancestors suffer from diabetes or heart disease that we automatically have to be relegated to suffering that same situation. Have you heard about the middle passage theory of high blood pressure?
I can't say that I have.
So and again, we don't know if it's how to prove it necessarily, but there's a theory out there that it took 3 or 4 months for us to be put on slave ships and then transported over here on the ships. A lot of the slaves didn't make that middle passage, that 4-month transit from Africa to the United States, and they perished, on the ship, and they were, thrown overboard. The theory is that those of us, our ancestors who survived that middle passage, are the ones living in America now, obviously, and they survived because their bodies genetically were predispositioned to be able to retain salt, more so than the individuals who became dehydrated and died during that transit over here. And so as a result, the theory is that's why many of us today have a higher incidence of essential high blood pressure, hypertension, because our bodies are genetically programmed to retain salt.
Okay. Well, I'll add to that, and I'm not a physician. I can't give medical advice as you can, but I know that there's a difference between the table salt that we use and sea salt that has trace minerals that that the other salt doesn't have, because basically they take everything out and then add some potassium chloride so that it, flows freely or whatever. So, but I would also say that, just like we make the genetic connection to our ancestors, we also have to look at the fact that we pass down a diet, from generation to generation. And that might be one of the factors, and in addition to the epigenetic concerns. We just have a few moments left, and we've had such an interesting conversation about those two diseases. But I would be remiss if I didn't give you an opportunity to talk about It Isn't Difficult to Do If You Know How to Do It. Talk to us about the genesis of that book, and also let us know how we can get our copy of it.
Yeah, so the book is on Amazon. It's on Barnes & Noble, online, and selected bookstores, locally, libraries. I actually updated the title about a year ago. So and there's a workbook also by the same title. So the title is Yes, You Can Succeed, and then It Isn't Difficult to Know How to Do It If You Know How to Do It. It isn't difficult to do it if you know how to do it. And that's kind of a funny title, and some people say it's kind of nonsensical, but that title came about. My daughter, Hannah, she's actually 27 years old now. She's a biomedical engineering student at Cleveland State. She, about a year ago, got her chemical engineering degree, but when she was 3 years old, we had a nanny at the time, babysitting her, and Hannah was busy playing a video game with the joysticks, and the sitter was, said, Hannah, that looks very difficult to do. Is it difficult to do it? And then without missing a beat, Hannah, a 3-year-old, goes, it isn't difficult to do it if you know how to do it. And when you think about it, it's not a nonsensical statement. It's actually very profound. I put it up on there with quotations from Plato and Aristotle, and I wrote about it. There's a whole chapter about it in the book. It basically means if you're a young student or a person of any age, and if you have aspirations to succeed in life at whatever you wish to accomplish or achieve, if you know how to do something in advance, that means if you will understand the importance of getting a mentor, speaking to somebody who has already achieved some of the successes that you wish to achieve, learn from your mistakes, learn from their mistakes, your lived experiences, their lived experiences, your path to your success will be less difficult than what it otherwise would have been. And this book is about 400 pages. I say all the time, I wish I would have known the content of this book when I was going through my journey in terms of becoming a surgeon. My pathway would have been a lot easier. I've learned from my mistakes. I've learned from others' mistakes. But this book is really replete with success navigation tips and tools that you're not going to learn in a classroom.
Okay.
I would say
that it is definitely a tool that can be used. We're out of time, Dr. Modlin, but I want to invite you to come back when those developments that you spoke of come into fruition. We'll have this conversation and we'll talk more about the book. You can go to Amazon to get It Isn't Difficult to Do It If You Know How to Do It. Thanks for joining me, and thanks for listening. As always, know yourself, love yourself, be yourself. Make today your absolute best day. Peace.